we were interested in, the patients that come with the first ever stroke, and in a third of them, you see that previously there was already ischemic injury to the brain. You see gliosis, it might be small vessel disease such as lacunes or subcortical white matter disease, but it might also be embolic phenotypes involving the cerebellum or the cortex. And we asked ourselves how those patients differ, and we could show that those are vascular high-risk patients, so those that had already suffered a covert prior brain ischemia. They have much more vascular risk factors. And also that pathophysiology would differ between those patients. For example, we could show that the cortical ones that you would presume they are embolic, they are indeed independently of Chet's-Vasc associated with atrial fibrillation. So maybe the prior brain ischemia that can also help us in determining the stroke etiology and the best secondary prevention. I think there's been a lot of epidemiological studies that clarified that those are not benign incidental findings that we can ignore. As a matter of fact, the ICD-11 classification of diseases now for the first time incorporates covered brain infarction as a disease entity. It's a novel disease entity. It's termed silent brain infarction, which has to do with the fact that, the process of incorporating this disease takes a lot of time. And it was only in the last years that the term silent brain infarction is not longer recommended, but covered brain infarction should be preferred. So I think in ICD-12, it might be covered brain infarction, but for the moment, I'm very happy that ICD-11 incorporates it. And there has been an ESOC statement also on covered cerebrovascular small vessel disease. So the statement is only applicable to patients who have covered white matter hyperintensities or lacunes. But for those, it's a clear statement that those patients should be seen, vascular risk factors should be addressed and optimized. And for the other ones that are non-small vessel disease phenotype, we can use the American Heart Association scientific statement, which also argues for a vascular checkup and an individualized workup to assess common causes of embolism, such as carotid artery disease or atrial fibrillation.